Well, good evening, everyone that's joining us this evening for our second webinar in our brand new practitioner series. A very warm welcome to you. Today's topic is all about insulin resistance and blood sugar balance. My name's Emma, and I'm part of the team at DR.VEGAN. We also have with us today as our host, DR.VEGAN practitioner lead, Ella, and our guest host this evening is Mark Killick, who is a registered functional nutritionist. So welcome to you both. Before I start, I just want to quickly mention as a disclaimer that our practitioner webinars are intended only for professionals and not members of the public. This includes trainee nutritionists, nutritional therapy practitioners, dietitians, naturopaths and pharmacists, and probably a lot more other people as well. Before I hand over to Ella, I want to give a brief introduction to both of our hosts this evening. So firstly, Ella, as I mentioned, is the practitioner lead at DR.VEGAN. She has a passion for practitioner education and has previously worked in a lecturing and clinical supervisor role as one of the major nutritional therapy training institutes. Ella has since put her passion for education into training practitioners at DR.VEGAN and creating materials to make clinics easier and more efficient. We're thrilled to also welcome Mark Killick as our guest host this evening. Mark is a leading expert in nutrition and functional medicine. He's worked with everyone from England footballers all the way to local GP surgeries. Mark is passionate about tackling type 2 diabetes and cardiovascular health. Now, just before I hand over to Ella to kick things off, I wanted to add, please feel free to ask any questions throughout. We're going to have a short Q&A at the end where Ella and Mark will be answering your questions. We'll probably only have time to go through a few questions at the end, depending on time. So if yours doesn't get answered or if you don't, for some reason, feel comfortable asking any questions this evening, then please reach out to Ella. She will be able to help. She'll be sharing her email address at the end. So without further ado, I'm going to hand over to Ella.
Thank you so much for that fantastic introduction, Emma. We've got today's webinar on insulin resistance and blood sugar balance. And today we're going to be discussing a few topics, including an introduction to insulin resistance, understanding insulin resistance properly, the role of exercise in insulin resistance, maintaining metabolic flexibility, sleep, stress, and their impact on insulin resistance, practical assessments.
I'm really sorry to interrupt, but the slides aren't shared at the moment. So if you wouldn't mind just sharing your screen, everyone will be able to see those.
Yeah, absolutely. Sorry. Just give me a second. Okay. Okay, can you see it now?
Yep, can see those.
There we go. Okay?
Yeah.
Perfect.
Thank you.
Okay, so maintaining metabolic flexibility, which is obviously very important in preventing insulin resistance and reversing insulin resistance. Stress, sleep, and their impact on insulin resistance. Practical assessments and diagnostic tools. Naturopathic strategies for insulin resistance. And an introduction to glucobalance, magnesium, and omega-3. Okay, so before we get started, let's have a look at a few statistics. So as of 2021, approximately 537 million adults, that's adults between the age of 20 and 79 years old, worldwide are living with diabetes. That equates to 1 in 10 individuals. This number is projected to rise to 783 million people by 2045. That's an astonishing amount of people. In 2021, the United Kingdom reported nearly 141,000 deaths attributed to diabetes, making it the third highest figure across Europe. So out of Europe, we're the ones that have one of the major problems with insulin resistance. Okay, so worldwide prevalence of insulin resistance among adults ranges from 15.5% to 46.5%, with some regions reporting rates as high as 66.3%. Between 2013 and 2019, official estimates indicate that 7 to 10% of adults in England had diabetes each year. And finally, approximately 6.3 million people in the UK have pre-diabetes, a condition that significantly increases the risk of developing type 2 diabetes. So with statistics like that, really it's quite incredible that more isn't being done to prevent diabetes, prevent insulin resistance, and research into reversing it. But myself and Mark are going to give you some fantastic strategies for your clinic today. So hopefully that's going to help you.
Yeah, just one thing there is I don't think people realise the long-term implications of diabetes as far as cardiovascular disease, vision problems, kidney damage, and a stroke, and a whole host more. You know, it's just almost like I've got diabetes, but they don't actually understand that they then have a risk of developing some very serious conditions with that. So just thought I'd put that in at that point.
Fantastic. And of course, you can lose limbs from diabetes, can't you? And, you know, increased risk of cancers. So it's not just a condition in its own right. It then does put you at higher risk of other horrible effects and other diseases that are associated with insulin resistance. Thank you for adding that in there, Mark. Okay, so look at this nice little diagram here. Insulin is a hormone that's produced by the pancreas and plays an essential role in the regulating of blood sugar levels. The insulin receptor is a transmembrane receptor that mediates the effects of insulin on glucose metabolism. The insulin receptor is a tyrosine kinase receptor that upon binding to insulin undergoes autophosphorylation and activates a cascade of downstream signaling pathways. These pathways regulate various cellular processes, including glucose uptake, glycogen synthesis, and protein synthesis. Glucose is transported into cells through a process mediated by the GLUT4 transporters, specifically glucose transporter type 4, which is shortened to GLUT4, and you'll see that on the diagram here in the middle of the cell on the left. GLUT4 is an insulin-regulated glucose transporter that is responsible for insulin-stimulated glucose uptake in skeletal muscle and adipose tissue. In the absence of insulin, GLUT4 is sequestered into intracellular vessels called GLUT4 storage vessels. Upon insulin stimulation, GLUT4 storage vessels fuse with the plasma membrane, allowing GLUT4 to facilitate glucose uptake into the cell. So this is moving on to the second image here on the right. So we've got a nice little picture of what's going on there. GLUT4 vessels are dynamic structures that undergo constant movement and fusion with the plasma membrane. The mobility of GLUT4 vessels is regulated by the actin cytoskeleton and myrinase motors. Insulin stimulation triggers a translocation of GLUT4 vessels in the plasma membrane, where they fuse to allow glucose to enter the cell. The process of GLUT4 translocation is tightly regulated. Now here we have a wonderful flowchart of exactly what happens from start to finish. So first we have the pancreas that produces insulin, and the insulin binds to insulin receptors. As mentioned earlier, these are called tyrosine kinase receptors. And then autophosphorylation of the receptor happens, activation of the downstream signaling pathway. And we have regulation of cellular processes, including glucose uptake, glycogen synthesis, and protein synthesis. We've got GLUT4 storage vessels are then mobilized. GLUT4 insulin regulates glucose transporters. The actin cytoskeleton and myrinase motors facilitate GLUT4 vessels translocation, GLUT4 fusion with the plasma membranes, and that increases glucose uptake into the cell. Mark, do you have anything to add here to this process?
Yeah. I mean, I think when we're talking about insulin resistance, you know, how does that happen? So one of the things to actually point out is that cells have a finite number of the insulin receptors. So the process that you've just described, where the insulin will bind with the receptor and cause the translocation of the GLUT4 transporter. Once the glucose has been uptaken into the cell, that insulin receptor is in itself drawn back into the cell, where the actual cell then breaks it down. So it has to. If we continue with a situation where there's an increase in blood sugar, the cell then has to make another insulin receptor to put that into the cell membrane to carry on the process. So you can see where we get a situation where people sort of continue to increase the glucose within the blood, and then the cells cannot keep up with the insulin receptors, and that's where we can actually end up with an insulin resistance process starting to take place.
That's really interesting. Thank you so much for that input, Mark. And of course, insulin resistance, of course, is a condition where the body cells become less responsive to insulin, as Mark just mentioned, leading to impaired glucose uptake. And that impaired glucose uptake can lead to hyperglycemia, so too much blood sugar, basically, circulating. Insulin resistance is also the major hallmark of type 2 diabetes mellitus. So they can occur separately. So you have insulin resistance without diabetes, or insulin resistance with diabetes type 2. And as Mark mentioned earlier, they are often accompanied by other metabolic disorders such as obesity and dyslipidemia. And in insulin resistance, the insulin signaling pathway is also impaired, leading to reduced glucose uptake in skeletal muscle and adipose tissue, leading to things like tiredness and fatigue. And this impairment is often due to the serine phosphorylation of insulin receptor substrate 1, which inhibits the insulin signaling. Now, insulin resistance has several consequences, including impaired glucose uptake in skeletal muscle and adipose tissue, hyperglycemia, hyperinsulinemia. Insulin resistance also increases like cardiovascular disease dramatically, and other metabolic disorders can be a massive problem. And in insulin resistance, beta cell dysfunction is often an issue, and that ultimately results in the development of type 2 diabetes mellitus. And, unfortunately, once you've gone that far, it is possible to bring somebody back from type 2 diabetes mellitus, but it's much easier if they haven't got that far yet. So it's easier to kind of prevent that and bring your clients back from insulin resistance before it goes all the way to type 2 diabetes mellitus. And there are a few things that we can do for the treatment and management of insulin resistance. Okay, so there's several lifestyle factors that can affect insulin sensitivity. And one of these is excessive sugar and processed carbohydrate intake. So really have a deep dive of your client's diet. What are they disclosing and what are they not disclosing? Because don't forget, you can ask them to do a 24-hour recall, or you can do them a 3-day food diary. But are there things on there that they're not necessarily disclosing? Maybe the odd Mars bar here and there, which they conveniently forget to put in. Consuming high amounts of sugar and processed carbohydrates can lead to insulin resistance. So the rapid spike in the blood sugar levels triggers the insulin surge, which then over time kind of makes you resistant to that. And furthermore, a diet high in sugar and processed carbohydrates can lead to chronic inflammation, and that is also associated with insulin resistance. So it's a double whammy. Not only does it create insulin resistance on its own, but the carbohydrates also promote the inflammation within the body, which then also promotes insulin resistance. And a study published in the Journal of Nutrients found that consuming beverages sweetened with fructose, glucose, high fructose corn syrup, sucrose, and aspartame for 2 weeks. So this is only for 2 weeks, and it's not just sugar, it's the sucrose and it's the aspartame, and it's all these other things they're adding to drinks. It negatively affects insulin sensitivity in young adults. That's just after 2 weeks, so even aspartame does that. The effects of sugar and processed carbohydrates intake on insulin resistance are particularly concerning, as they lead to a range of metabolic disorders, including type 2 diabetes and cardiovascular disease. And then we've got a sedentary lifestyle. So it's really important to work out or to ask your clients, what exercise are they doing? How long are they doing it for? Are they monitoring their heart rate? Are they sweating? So a sedentary lifestyle is a significant risk factor for insulin resistance. It leads to decreased insulin sensitivity and, again, increased inflammation. Whereas regular physical activity, on the other hand, can actually improve insulin resistance and reduce the risk of developing type 2 diabetes. A study published in the Journal of Diabetes found that cumulative daily physical activity is a major determinant of insulin sensitivity. and that even small amounts of physical activity can have a positive impact on insulin sensitivity. And furthermore, a sedentary lifestyle can lead to chronic inflammation, which is also associated with insulin resistance. So again, here, just to point out, even a small increase in physical activity has a massive impact on insulin resistance. So if you've got a client that's chair-bound, you can get them doing chair yoga or chair aerobics, and that in itself is going to help to some degree with insulin resistance. Okay, obesity and the viscerals, especially visceral fat obesity. So that's fat around the middle. So these are major risk factors for insulin resistance, and they are associated with a range of metabolic disorders as well, not just insulin resistance. A study published in the Journal of the Association of Physicians of India found that visceral abdominal fat thickness was significantly associated with insulin resistance in pre-diabetic subjects. Furthermore, obesity can lead to chronic inflammation, which is then also associated with insulin resistance. So what you've got to think about with your clients is that visceral fat is significantly increasing inflammation, which then not only contributes towards the formation of insulin resistance, but it's other health conditions as well. So you need to getting them losing weight and having a healthy BMI, because this also increases their risk of things like cardiovascular disease and other metabolic disorders as well. So it's that cumulative effect. Okay, so we've also got chronic stress and high cortisol. So who isn't stressed these days? Honestly, it's like everybody. And actually, high cortisol levels, particularly prolonged stress, can contribute to insulin resistance, again by causing that inflammation and impairing that insulin signaling. And a study in the Journal of Hormones found that cortisol was moderately increased in insulin-resistant obese children, and that was related to insulin resistance. Furthermore, the study published in the Journal of Nature Reviews Endocrinology found that work-related stress was associated with increased risk of developing type 2 diabetes mellitus in women. So even something as simple as getting your clients to go for a quick half-an-hour walk on their lunch break can help to relieve stress, and also that's increasing their physical activity as well. And Mark's going to discuss a little bit later about post-meal gentle exercises. So there's something as simple as that can be really, really helpful to our clients. Okay.
There was one other thing actually missing from the list.
Yes.
If you don't, it's just the introduction of seed oils into the human diet. There's quite a strong correlation between increase in type 2 diabetes and when seed oils became, an integral part of the human diet. If you go back 100 years, we had very little seed oil as far as our ingestion was concerned, and then when we get to the sort of 1950s, we see more and more sort of seed oil being used for processing, such as margarine, and also within food processing itself. Looked into it, and it's not necessarily the sort of like the omega-6 fatty acids that we find a lot of within the seed oil, so the sort of linoleic acid, but often it's how they actually become damaged in processing and create certain peroxidases, which then create more and more inflammation in the body, which then leads to more cytokine release, which is part of the process of sort of like inflammation and then more insulin resistance taking place. And also we've got to think about how these seed oils fit into the sort of cell membranes and how they affect the sort of translocation of the GLUT4 transporter into the membrane itself, and that sort of like then leads to further insulin resistance at a cellular level. So just adding my 2 pennies about seed oils, so.
Fantastic, thank you, Mark. And I always recommend my clients to use either very high quality olive oil, coconut oil, or avocado oil to cook with. What about you, Mark? What do you recommend for your clients?
Sorry, I'll just come off me. Yeah, I'm with you on that totally. So and actually, I mean, I the other thing is just to avoid processed foods, because you'll see that one of the major ingredients of that will be sunflower oil, and there will be some damage to that sunflower oil in the whole processing from when it was made to when it was sort of used in the food processing itself. So yeah, I'm with you on your oils.
Perfect.
Just quickly, Ella, someone's popped a question in the chat just asking if we can point them to the research about the seed oil and the to DM. So perhaps either if you're able to share that now, or you can share it at the end. I'm sure it'd be useful for other people on this call as well.
Yeah, absolutely. Yeah. I don't have it on my screen, but I'm sure that's something we can share at the end. Do you have it, Mark?
I'll have a look at that, and I'll bring it back to you. Yeah, all right.
Perfect.
Thank you.
Thank you so much. Okay, so let's have a look at genetic factors. So genetic factors do have a role to play in diabetes. Many people that go on to develop insulin resistance type 2 diabetes have the genes to start with, but having the genetics is like having the loaded gun. You have to pull the trigger, and that trigger is diet, lifestyle, stress, and all those other things that we've discussed just now. So just because you've got the genes, it's not the end game, it's not a death sentence, it's not a diabetes sentence. You can stay fit and stay healthy and stay metabolically flexible with those genes. But it is helpful to know. And it does take a whole webinar in its own right. It is such a deep topic. So I'm not going to go into it in too much depth right now. But I just want you to be aware of the several gene variants that are associated with diabetes. And that is the IRS1 and IRS2 gene variants, the PPARG gene variants, the TCF7L2 gene variants, the SLC2A4 gene variants, the KCNJ11 and ABCC8 gene variants, and the HHEX and CDKAL1 gene variants. So if your client has a genetic test, they've got any one of those, what you need to be doing is having a deeper dive into kind of exactly the mechanisms that these contribute towards diabetes and insulin resistance, and really putting a plan together that's focused on that particular gene and that particular mechanism.
Yeah, the PPAR gamma gene variant, PPAR gamma will actually sort of increase the production of adiponectin, or it stimulates the production of adiponectin, one of the hormones made by the adipose tissue, which will sort of help with insulin sensitivity and help with the fat getting stored subcutaneously rather than sort of viscerally around the body, which would actually then lead to more inflammation and the potentiality for more insulin resistance. So yeah, PPAR gamma is one of the ones I always look for.
Perfect, thank you, Mark. Okay, so let's have a look at nutrient deficiencies. So obviously nutrient deficiencies do also play a huge role in insulin sensitivity, and your body does need certain nutrients to maintain that metabolic flexibility. And one of those nutrients is vitamin D, which is crucial for maintaining insulin sensitivity. And so many people are vitamin D deficient these days. I try and get all of my clients tested and make sure they've got optimal levels, give them a good vitamin D supplement as well. So deficiency has been linked to insulin resistance, and a study published in the Journal of Clinical Endocrinology and Metabolism found that vitamin D supplementation improved insulin sensitivity in patients with type 2 diabetes. And magnesium is another essential mineral that plays a crucial role in glucose metabolism and insulin signaling. And deficiency has been linked to insulin resistance. A study published in the Journal of Calcium found that magnesium deficiency was associated with insulin resistance in patients with type 2 diabetes. And chromium is a very famous mineral. Everybody knows about chromium and blood sugar balance. And that's because of its essential role that it plays in carbohydrate and fat metabolism. Chromium deficiency has been linked to insulin resistance, and a study published in the Journal of Nutrition found that chromium supplementation improved insulin sensitivity in patients with type 2 diabetes. Now, Mark, I believe you've got some interesting nuggets of information on chromium.
Yeah, well, chromium sort of gets transported to the cell via transferrin, and once it's in the cell, it actually sort of binds with a protein within the cell, and that protein called chromoglobin, and that protein in turn binds to the insulin receptor, making it a little bit more sensitive. It prolongs the kinase activity within that insulin receptor, so therefore we can get more glucose transported into the actual cell. So yeah, chromium is one that we should look out for. I mean, sort of things like broccoli, high in chromium, brewer's yeast, that sort of thing. So yeah. A few different things to look at.
Thank you, Mark. And also when we want to be having a look at zinc, again, because that is essential for glucose metabolism. And zinc deficiency is also a major player in insulin resistance. And a study published in the Journal of Nutrition found that zinc supplementation improved insulin sensitivity in patients with type 2 diabetes. Zinc deficiency can impair insulin signaling by reducing the expression of insulin receptor substrates and increasing the expression of inflammatory cytokines. And again, vitamin B12 is another essential nutrient. And a study published in the Journal of Clinical Endocrinology and Metabolism found that vitamin B12 supplementation improved insulin sensitivity in patients with type 2 diabetes. Vitamin B12 deficiency can impair the insulin signaling, which then reduces the expression of IRS1 and increases the expression of inflammatory cytokines. Now, omega-3 fatty acids, so many people do not consume enough omega-3 fatty acids, but they are actually also essential. And a study published in the Journal of Nutrition found that omega-3 fatty acid supplementation improved insulin sensitivity in patients with type 2 diabetes. And finally, folate is another big one for insulin resistance. A study published in the Journal of Nutrition found that folate supplementation improved insulin sensitivity in patients with type 2 diabetes. And a folate deficiency can impair insulin signaling by reducing the expression of IRS1 and increasing the expression of inflammatory cytokines. So make sure that your clients have got a folate in a form that they can use. If they've got any MTHFR genetic variants, make sure you're giving them methylfolate rather than folic acid. Okay, let's have a look at the main causes and triggers of insulin resistance. I'm going to start at the top on the right and I'm going to move clockwise. So obesity and visceral fat, we've already discussed that a little bit earlier, but simply because it leads to chronic inflammation, which then impairs insulin signaling and disrupts the whole insulin signaling process. So first thing we need to do is get that the central obesity off, get your clients to a healthy weight. And again, physical inactivity. So your client might be a perfectly healthy BMI, but they might be physically inactive. And physical inactivity in itself can lead to insulin resistance. Mark's going to discuss that a bit later on, which I'm quite excited for because he's got some really good information on that. So physical activity can then, promote insulin sensitivity. So we need to get all of our clients moving. Okay, chronic stress. Also, as we mentioned earlier, can lead to insulin resistance. So get your clients doing Tai Chi, yoga, meditation. And sleep deprivation, again, because that disrupts the circadian rhythm and that can lead to inflammation and disrupt sleep patterns, and that can lead to impaired glucose metabolism. And hormonal disorders as well, such as polycystic ovary syndrome. So it's kind of a catch-22 because if you've got insulin resistance, that can contribute towards the development of polycystic ovary syndrome. But then if you have polycystic ovary syndrome, that can also contribute to the development of insulin resistance. So make sure you're getting that sorted in your female clients that have that. And as we mentioned earlier, you've got those genetic predispositions, which you can look more at depth in if you need to. So we've talked loads and loads about inflammation, but it's so important to put your clients on an anti-inflammatory diet. Give them an anti-inflammatory lifestyle. Are they walking barefoot every day in the grass? They should be. Are they switching off all their electronics and switching off their Wi-Fi router at night before they go to bed? Absolutely, they should be. These kind of lifestyle factors, along with an anti-inflammatory diet, are going to help their metabolic flexibility. Non-alcoholic fatty liver disease in itself can contribute to insulin resistance. So again, there's a catch-22, like the polycystic ovary syndrome, they can cause each other. So just make sure that you are targeting that if your clients have that as well. And gut microbiome imbalances can also lead to insulin resistance. So that's another topic, huge topic in itself. But if you do not have a healthy gut microbiome, that can dramatically impair your glucose metabolism and your metabolic flexibility. Toxin and pollutant exposure as well can also impair metabolic flexibility. So make sure your clients are having as toxin-free lifestyle as possible. So get all the plastics out, get all the perfumes out, get all of the air fresheners out, and get them to have a nice, clean, healthy, low toxin lifestyle. And some medications as well that people take, steroids, certain psychiatric medicines, they can also affect insulin sensitivity. And although it's not our place to tell people to stop taking medications, we can certainly tell them to have a discussion with a doctor, see if there's any alternatives, or actually, do they really need this medication? That's a conversation we can encourage them to have.
Yeah. On that note, there's some very common medications that, as you mentioned, corticosteroids will raise blood sugar. Also, beta blockers. They will actually sort of stop the peripheral circulation to a certain extent, so stopping the glucose getting into muscle cells, and also they'll have an effect on this sort of beta cell production too. And the other ones, the common ones, statins, can sort of increase insulin resistance as well. So yeah, there's quite a few meds that can make a difference. All right.
That's quite incredible, isn't it? Considering that they put you on statins to reduce your cardiovascular risk, but then you might get insulin resistance and then diabetes, which then increases your cardiovascular disease risks. It's the irony of it. Okay, so let's have a look at the differential diagnosis. So things that you need to watch out for in your clients that do have insulin resistance. So number one is type 2 diabetes. Is it insulin resistance, or do they actually have type 2 diabetes? Now, Mark is going to talk about testing a little bit later on, but basically you need to send your clients for a fasting plasma glucose, oral glucose tolerance test, or HbA1c. So these are your starting points, and Mark is going to discuss a little bit more about testing insulin levels later on. Again, polycystic ovary syndrome, as I mentioned on the previous slide, or get your female clients tested for that if they do have some symptoms also, or kind of make sure you're asking in your questionnaire around those symptoms. Cushing syndrome, that's a rare endocrine disorder caused by excess cortisol production, and as we know, excess cortisol production can lead to insulin resistance. And hypothyroidism as well. So make sure that your clients are being tested for hypothyroidism, and not just the general, T4, TSH. Get them tested for the T3 and reverse T3 as well. So you might have to do that privately because it's not normally available on the NHS. But make sure that you're checking that and correcting those abnormalities if they are there. Acromegaly, that's a rare endocrine disorder caused by excessive growth hormone. That can lead to insulin resistance and weight gain and other metabolic disorders. Mitochondrial disorders as well. So these are rare genetic disorders that affect mitochondria, leading to insulin resistance and other metabolic complications. And finally, autoimmune insulin receptor syndrome, which is a rare disorder characterized by autoantibodies against insulin receptor, leading to insulin resistance, metabolic abnormalities, and other complications. So if they do have an autoimmune problem, you need to encourage metabolic flexibility to also re-regulate that immune system and the gut. Okay. Continuous glucose monitors. Mark, you know a lot about these monitors. Do you want to share with us your nuggets of information?
Yeah, so it's something that I do encourage most of my sort of clients to use. I often ask the doctor whether they prescribe it, and often I get a no, but which is such a shame. But what it does is it empowers the client to see what particular foods are actually causing a problem with their blood sugar levels. For instance, some people could even be sensitive to the effects of caffeine. That can raise their blood sugar levels. And also, it's quite nice to have a look at how the liver's playing a part. So, are we getting a dawn effect where we get blood sugars increasing as far first thing in the morning? So yeah, I use them a lot for clients just to sort of empower them and see which foods are making a difference, because different foods affect people very differently. So they're something that is vital in my practice for working with clients. Yeah.
Fabulous, thank you, Mark. And the other thing that I'm a major fan of with insulin resistance is intermittent fasting. So it's actually been shown to be a very effective way to improve insulin resistance. And intermittent fasting involves restricting calorie intake for a certain period of time throughout the day. And studies have demonstrated that intermittent fasting can lead to significant improvements in both insulin sensitivity and even in people who already have type 2 diabetes. And intermittent fasting helps you to use up your glycogen stores and really to resensitize your body to insulin. So the normal fast is 14 to 16 hours. So you eat within an 8-hour window. So whatever is more suitable for your clients, maybe they have a later breakfast or maybe they have an earlier dinner, but make sure they are sticking to those 8 hours and having that 14 to 16 hour fast overnight. Just, I want to say on a note there, be careful with your female clients if still menstruating. So fasting requirements of women who are menstruating are different. So in that 2 weeks before menstruation, you don't really want to be letting your women go for more than 12 hours, more than a 12-hour fast. And this is because for progesterone prefers a slightly higher carb environment. So make sure you do time the cycle, have the 2 weeks of 8-hour fast and then the 2 hours of the 12-hour fast. And again, this is a whole entire webinar in its own right, so something you can look into if you've got a lot of female clients with diabetes or insulin resistance. Okay, so let's have a look at the low GL foods and ketogenic diet. I'm a massive fan of low GL eating and ketogenic diet, and they have been shown in research to significantly improve insulin resistance. Low GL foods, they're the ones that are digested and absorbed slowly, looking at a gradual increase in blood glucose levels. So we're thinking proteins, whole grains, beans, like low GL vegetables, cauliflower, spinach, cabbage, these kind of things. And also you can make a meal more have a lower glycemic load by adding more protein and a little bit of healthy fat as well. And ketogenic diet, which is high in fat, low in carbohydrates and has moderate protein, has also been shown to improve insulin sensitivity and reduce inflammation. And studies have demonstrated that both a low GL and a ketogenic diet are suitable for those with type 2 diabetes and help to encourage metabolic flexibility. Now, whether I choose a low GL diet or a ketogenic diet really depends on the client, what else they've got going on in their life, what other dietary restrictions they have, and kind of like, is it urgent? Is it, is insulin resistance really that bad that we need to put them on a ketogenic diet straight away? Or will they be better off on a long-term sustainable, low glycemic load diet? It really depends on the client and their situation. Okay, Mark, you're going to talk about exercise. Oh, I can't hear you, Mark. Could you put your microphone?
I didn't press the button. So yeah, no, exercise is extremely important for bringing back that metabolic flexibility with clients. Muscle is one of the sort of key customers when it comes to glucose. So, and it's also one of the first tissues to sort of become insulin resistant. So when we talk about sort of glucose uptake in muscle, we are talking about the GLUT4 transportation, but also muscle will take up glucose without the need for insulin to a certain extent. So the more that we can get our clients to exercise, maybe even build muscle, we're going to increase that demand for glucose and start to mop it up as far as the blood's concerned. Resistance exercise will be important because, to build a little bit of muscle will also increase the demand for glucose, so we bring back that insulin sensitivity.
Fabulous. And what's your favourite type of exercise, Mark, for those with insulin resistance or diabetes?
The ideal tends to be the mixture of sort of using a certain weight training routine to build muscle alongside maybe a HIIT type exercise class to sort of create that sort of aerobic demand for glucose within the muscle. So yeah, it's a combination of the both. However, obviously not every client is going to be able to achieve that. So even getting your client to sort of walk is just as important, and it's still something that I will use even with the clients that can do the HIIT exercise plus lift a few weights. So yeah.
Fabulous, thank you for that. Okay, so probiotics, so the last one on this slide. Probiotics and the gut microbiome have a huge effect on insulin resistance. and they do actually play a large role. So there's been lots of studies, several studies showing in rats and mice, where they do fecal transplantation, and they really change the microbiome, and the mice can either become insulin resistant or they become resensitized to insulin depending on the microbiome changes. So it's really, really important to make sure that your clients' guts are working effectively. You know, are they eating enough fiber? Have they got SIBO? Have they got candida? Have they got anything else going on in their gut that could potentially be causing a problem with insulin resistance and diabetes? You know, making sure they're having loads of fermented food if they can tolerate it, making sure they're having a daily probiotic. These are really, really essential things that we should be looking at in clients with type 2 diabetes. Okay, Mark.
Yeah, I'm in now. So thank you, Ella. You know, so that was a great introduction to my slides. And we've spoken about sort of all the risk factors involved for hyperinsulinemia and also hyperglycemia, leading to type 2 diabetes. So, yeah, where are we actually going wrong? Because as Ella pointed out, the increase in people suffering with type 2 diabetes is increasing year on year. One of the reasons maybe we're going wrong is we don't actually measure insulin. So this graph here, if you can see it, shows the sort of progression of insulin resistance to type 2 diabetes, and we can look at different aspects as to what's happening on a sort of physiological level. One of the things and let's just look at the glucose levels to begin with. These don't start to rise until a long way into the sort of like the process of diabetes development. But what we do find first and foremost is that insulin starts to rise because the cells are becoming insulin resistant. So we see this rise in insulin resistance along the rise in insulin taking place first and foremost. Often sort of goes hand in hand with maybe a sort of increase in adiposity, so sort of increase in obesity, etc. But this is what happens first, and we can see that we get more differentiation of our beta cell mass within the pancreas. So that's to meet the demands of the extra sort of insulin output. But after a while, we can see that starting to fail. It starts to fail because it actually can't keep up with demand. And this is the point that we actually see blood sugar levels start to rise to the point where someone may get a diagnosis of diabetes. So, yeah, you know, sort of like we get a 2 times increase in insulin levels prior to insulin resistance. And also the hyperinsulinemia can precede the hyperglycemia by up to 25 years. So I think there's a lot more that we can actually do for clients that we're not doing at the moment. We're sort of like allowing them to progress with a very pathological disease when we could actually be making some kind of intervention far earlier on. So the scenario here is we can actually have a client that's gaining weight, you know, maybe a little bit hypertensive, you know, high blood pressure, but we measure glucose and everything's quite stable. So we assume that there's no metabolic problem, but if we measured insulin, we might actually discover that there is a metabolic problem taking place. When we get this insulin resistance as well, it starts to progress around certain organs. So the actual alpha cells of the pancreas will become insulin resistant. What that means is that they would still continue, because the insulin would stop the alpha cells' production of glucagon, but because they're insulin resistant, they will still produce the glucagon, which will then signal the liver to start to produce glucose from its glycogen store. So we start to see this steady rise in blood glucose levels. The liver itself becomes resistant to insulin. We start to get a buildup of fats within the liver itself, and also these free fatty acids. They start to lay down as fat around organs, which is that visceral fat that Ella spoke about earlier. Visceral fat, again, is far more inflammatory than subcutaneous fat. It's very hypoxic, so it sends out signaling to the immune system, which causes a migration of immune cells to the fat tissue, and an increase then in cytokine production within that visceral tissue, which has the effect of causing more and more insulin resistance. So looking at and then the progression goes to muscle cells, and their actual ability to pull in glucose starts to fall by about 50%. So what should insulin levels be? So if we measure fasting insulin levels, they should be between 5 to 15 milli-international units per litre, but under 12 is usually considered best. But we can see these levels start to increase to about sort of like 25. Usually about an hour after a meal, you can see it increasing even up to the high 200s. Yeah, and if this carries on, then the adipocytes, they become insulin resistant. We get increase in the free fatty acids within the blood, and also triglycerides in the blood. And actually, high triglycerides in the blood are actually a strong predictor of cardiovascular disease. And this is one of the predictors we can use when looking at a basic lipid test to see whether someone is becoming sort of insulin resistance. Yeah, next slide, if someone can put me on my next one. So yeah, yeah, what can we do about it? So there's a few things that we can do, and a few things that I do within my practice, and Ella's mentioned some of them. Time restricted feeding. Usually, just to add on that, sort of like usually the earlier eating window is sort of metabolically better. However, people have to work within their sort of like their working life, their family life, because it is very social to eat in the evening. But if you can work on a sort of like a 16/8 diet, sort of like where the 8-hour window is earlier in the day, that's usually better for trying to reverse the insulin resistance that's taking place. If we start to restrict carbohydrates, when we do this, we see blood triglycerides fall very, very quickly. And also you can't store energy as fat if insulin is low. We actually would need that. We would need to sort of use the fat for energy production in the body. So we start to see the fat cells start to shrink, and that actually sort of lowers inflammation within those fat cells, which is helpful for lowering inflammation around the body, and has an effect on sort of bringing back some kind of insulin sensitivity. I do get my clients to also prioritize sort of protein, not fearing fat, so the ketogenic diet is helpful. We can actually achieve a higher metabolic rate, and also calories can be wasted through via keto acids through the urine and the breath. So it's another way that we can bring about sort of a reduction in adipose tissue within the body, and therefore a reduction within inflammation. Yeah, bad fats. So the body needs both omega-3 and omega-6 fatty acids, but the typical Western diet is usually higher in the omega-6 to omega-3 fatty acids. So omega-6 fatty acids, when they're consumed in excess, can contribute to inflammation, and that's a key factor in the development of insulin resistance and also other conditions associated with it, such as obesity and type 2 diabetes. And omega-3 fatty acids, particularly EPA and DHA, they've been shown to improve insulin sensitivity and reduce insulin resistance in quite a few studies. So we look at the omega-6 to omega-3 ratio. So if we've got a higher omega-6 to omega-3 ratio, that can impair some of the insulin signaling that actually takes place at cellular level. And as Ella quite rightly said, focus on rebuilding your microbiome. So the gut microbiome plays a significant part in insulin resistance. There's specific bacterial species and their sort of metabolites which will impact insulin sensitivity. And so there's a potential when we have dysbiosis that is adding to the inflammatory load within the body and sort of increasing the likelihood of insulin resistance. And with that, if we've got dysbiosis within the gut, there can be a strong likelihood that we've got maybe sort of a impermeability within the gut barrier, which can lead to the gut crossing into the blood and causing an immune reaction there, which once again raises inflammation within the body. So it's something that I do work with clients, where I will work, or I will also work on their digestion as well, or ask them lots of questions regarding their digestion and trying to optimize that when working with diabetic clients. Reducing inflammation, so anything we can do there. So that can be, as we've already spoken about, increasing more of the omega-3 fatty acids. So making sure that if they are on a sort of meat-based diet, they can increase oily fish, and looking at other ways on plant-based diets to achieve that as well. But also talking to the clients about increasing their colourful fruits and vegetables and food, shown to improve insulin sensitivity, and also has that added effect of creating fibre, which can have a beneficial effect on the microbiome itself. So because free radicals once again increases oxidation, therefore can increase insulin resistance in the body. So specific antioxidants, so things like vitamin C, vitamin E, beta carotene, have all been shown to help bring back insulin sensitivity. And then finally, sort of like looking at sort of exercise, which we've spoken a little bit about, just to increase exercise will open the door for glucose transport into the cell. So it also helps with oxidation within the mitochondria. So we're bringing, as you saw earlier in the presentation, that mitochondria dysfunction can be part of the process of insulin resistance. So it's like there was a study that 12-week intervention of moderate to high intensity exercise showed a notable improvement in insulin sensitivity despite the continuance of a habitual diet and minimal weight loss. But if you do want to sort of achieve insulin sensitivity in a shorter time period, it would be worth using exercise alongside sort of weight reduction, which we probably could bring about with the removal of the sugars and carbohydrates. So, as I said earlier, when you're talking about exercise, the combination of aerobic and resistance exercise is probably the ideal way to go with clients. Aerobic will increase that glucose demand in the muscle, and the resistance exercise will build that muscle, so we end up with increased glucose demand further down the line, so we can bring back sensitivity. And the eventual aim with my clients is to reverse the type 2 diabetes. It can be a challenge with some, and others I've had some really good success stories, of which I'm going to tell you one now in a case study. So the case study was a guy, they call him Tony. He was a 46-year-old man, and his job was a wedding photographer. So he had a very poor eating pattern, sort of eating at very odd times of the day, and most of the time his diet was made up of many wedding breakfasts, and so quite a combination of rich foods that he was on for a long time. How did it present to him? Is it that he had actually quite high fatigue? So he presented to his doctor with fatigue. The doctor did the right thing. They measured his HbA1c, and they also did some other measurements as well. And they found that his HbA1c was 54 millimoles per mole. So he was within the diabetic range. And also his triglycerides at the time were 2.5 millimoles as well. So he actually got very minimal sort of like lifestyle diet advice, and actually they wanted him to go straight onto metformin. But he did seek me out because he didn't want to take the medication. So when he came to see me, I did some other sort of testing. So we looked at vitamin D, and he was 35 nanomoles per liter. So he was deficient, and also we looked at the omega-3 index and found that that was sitting at 4%, which is not ideal by any means. So what did we do with Tony? We reduced his carbohydrates and put him on sort of like a paleo-style low-carb diet, so not sort of full ketogenic, where I had him sort of like working out his macros in any way, but sort of, as I say, he was a meat eater, so we could use sort of like meats and vegetables and sort of like oily fish and vegetables. Also, he started to fast, so 16/8, so he started his eating at 10 a.m. in the morning and was generally finished by 6 p.m. Also gave him some advice as far as eating at weddings was concerned, you know, sort of what foods to look for, what foods to avoid, especially the wedding cake, and other little techniques, you know, which you may have heard about, sort of like eating the vegetables first, you know, that can help with the way in which we absorb the glucose, and also I did get him taking some apple cider vinegar prior to his meals, which once again slows down the absorption of the glucose into the blood system. We did some I didn't do some exercise with him, but I encouraged him to join the gym, and where he was doing weight training, and I still see him down that gym actually. And the other advice that I gave him was that walk after his last meal of the day. So when he finished eating at 6 o'clock, you know, he had a dog, so I was just encouraging him to, you know, go out for his walk then, because that would create demand for the glucose that he'd just eaten within his muscles as well. So I did supplement as well. So we optimized his vitamin D levels. We used some omega-3 fatty acids to try and increase his omega-3 index score. And also I used glucobalance, which I know Ella's going to be speaking about in detail later on. I particularly like the formulation. I think it's excellent. So that was something I used. Some B vitamins as well, just to help with sort of metabolism generally, and some magnesium. And anyway, so he stuck to my program for 12 weeks. He was full of energy. He'd lost a lot of weight, and actually also transformed his body composition as well, you know, with the weight training. And when he had that sort of HbA1c measured after that sort of 12-week period, it was down to 39. He's a real success story. Sort of like I still see him. He needs minimal further advice from me. He's changed his lifestyle, and I'm sure he'll actually go on to sort of maintain that sort of low sort of blood sugar readings that he actually has. Oh, he also did use a continuous glucose monitor as well, which he actually found very motivating, I would say, was probably because he could see that his blood sugar levels were low right from his first use of the plan that I gave him. So so all good there. So, and I think I give back to you now, Ella. Yeah. Are you there, Ella? Can anyone hear me? Hello?
I can hear you. I think she might have frozen.
Oh, okay, all right.
But I don't have control of the slides, which is an issue.
Okay. I'm still here.
That's fine. Bear with me. Let me just try and contact her separately.
Okay. All right. And so I might be able to sort of like
feel free to keep talking. If there's any other wisdom you'd like to impart.
Yeah. So one area that I haven't spoke about is that we can measure sort of like insulin, and we can also measure something called HOMA IR, which is HOMA and then IR, and that is what we call the homeostatic model assessment for insulin resistance, and is a method used to assess insulin resistance and beta cell function based on fasting glucose and insulin levels. It's a complicated formula. So you actually times fasting insulin by fasting glucose, and you divide it by 22.5. So it's telling me to reload the page. I mean, actually, I'm going to just I don't know whether anyone can sort of like put in the questions that they can hear me still. Can you still hear me in the question? Yeah.
Yes, sorry. I was just trying to speak to Ella to.
I can still carry on.
So sorry, Mark. I am listening.
Don't worry. So anyway, when you have a high HOMA IR value, it suggests a greater degree of insulin resistance. So, when we got a value of greater than 2, it's often considered indicative of insulin resistance. So, yeah, anything above 3.46 is, sort of like shows a considerable cardio metabolic risk. So that's another calculation that you can do with clients. Another question I'm often asked, because it's probably quite easy to measure blood sugar levels, but sort of like, where do you go to get insulin levels measured? And there is a sort of like a risk involved in the fact that you can get false readings if the sample's not taken correctly. So it's a sample that if exposed to heat, so a blood sample, if it's exposed to heat, that can cause problems as far as the results concerned. So a lot of the time you'll see insulin is actually sort of checked at the place where you actually have the blood draw done. However, you can centrifuge the blood sample, which will increase the shelf life of the insulin, so you can get an accurate reading. So, companies, I know Medichecks do an insulin panel. However, you will have to go and have the blood drawn, sort of like at a sort of clinic where they can then look at the insulin level straight after. So hopefully that was helpful to everyone.
Okay, can you hear me now?
I can hear
Yes, we can hear
fantastic.
you, Ella.
Thank you for filling in for me, Mark. I really don't know what happened to my internet there. I'm going to try and share my screen again and talk about our fantastic supplements at DR.VEGAN, which hopefully you'll find really, really useful for your clients. Can you see my slides?
Yeah, we can. Just Mark, thank you very much. That was great improv from you.
Okay, thank you. So there's a few supplements that we can use at DR.VEGAN, which work really, really well with insulin resistance. So the main one is glucobalance, which was formulated specifically for those with insulin resistance. And I'm going to talk about that in 1 second. But first, I want to talk about a couple of other supplements that I do use with my clients. And the first one is GutWorks. So as we mentioned earlier, it's really, really important to have that healthy gut microbiome. And GutWorks contains 50 billion probiotics. And I mean, that's an incredible amount of probiotics in one capsule. So please, do look into GutWorks and see if that's going to work for your clients, especially if they have got dysbiosis that's contributing to the problem. We've got a fiber complex, which is amazing for slowing down the rate of glucose, the rate that glucose enters the bloodstream. So having an additional fiber with that meal does slow down that whole process and helps the body to deal with that glucose more effectively as it comes through into the blood. Vegan omega-3. Now, this is a really, really good one because ours is from algae oil and that has EPA and DHA directly in it. So some other forms of plant-based omega-3, it's alpha-linolenic acid, which has to go through the conversion process, which can be inefficient. But because we do use algae oil, you have got that DHA and EPA, which can get straight to work in the body to help reduce that inflammation and normalize the omega-3 to 6 ratio. And magnesium, of course, we mentioned earlier, it was one of the minerals that is needed for normal insulin resistance. So magnesium helps insulin bind to receptors on the cells and improving insulin sensitivity. And it also helps to convert glucose into energy rather than letting it build up into the bloodstream. And to be honest, most people are magnesium deficient, so there is something that we want to look at. Okay, now on to the glucobalance. So glucobalance is one of my favourite supplements at DR.VEGAN, and the first ingredient it contains is cinnamon. Now, cinnamon contains the bioactive compounds like cinnamaldehyde and methylhydroxycalcone polymer, which increases insulin receptor phosphorylation and enhances glucose uptake by the cells. Cinnamon potentiates insulin directly by stimulating glucose uptake in the muscle and the adipose tissues. And we have fenugreek in there as well, which contains 4-hydroxyisoleucine, which is an amino acid that enhances pancreatic beta cell secretion. And in muscle cells, fenugreek promotes glucose transporter GLUT4 activity, increasing glucose uptake. Okay, myo-inositol. So myo-inositol is actually a precursor to inositol phosphorylglycans, which acts as a second messenger in insulin signaling. It promotes the P13-AKT pathway activation, which is essential for glucose uptake into the muscle and adipose tissues. And bitter melon contains charotenoids, viceins, and polypeptide P, which exhibit insulin-like effects, which helps to reduce the overall blood glucose levels. Bitter melon increases AMP-activated protein kinase, which is a key regulator of glucose metabolism. And bitter melon also increases GLUT4 translocation in muscle and liver cells, promoting glucose disposal. So really, really good combination we have in here. Apple cider vinegar. Now, this is an interesting one. Now, Mark mentioned earlier that he asked his clients to take that before their meal. And apple cider vinegar basically inhibits disaccharide enzymes and delays the carbohydrate breakdown, which increases the time it takes for glucose to reach the bloodstream. And apple cider vinegar increases glucose uptake into the muscles and reduces hepatic gluconeogenesis. Vinegar also enhances muscle blood flow, which may facilitate better glucose delivery into and uptake into the muscle cells. Alpha-lipoic acid. Okay, so alpha-lipoic acid is an amazing antioxidant and reduces oxidative stress, which is the main factor in insulin resistance and beta cell dysfunction. Alpha-lipoic acid mimics insulin, making it useful in improving glucose uptake into the cell with people with insulin resistance. And it works again through key signaling pathways such as the P38-MAPK and PI3 kinase, which are also activated by insulin. Alpha-lipoic acid blocks P38-MAPK, which reduces glucose uptake and helps control GLUT4 activity. Okay, so maitake mushroom. So maitake contain beta-glucans, which are polysaccharides that improve insulin sensitivity and glucose tolerance. Beta-glucans form a gel-like substance in the gut, which slows down carbohydrate digestion and glucose absorption. And this results in a gradual rise in blood sugar levels, preventing insulin spikes and reducing insulin resistance over time. Maitake helps sustain insulin secretion in response to glucose levels. And finally, we have in here chromium, which is one of our superstar nutrients for insulin resistance. Chromium increases insulin receptor phosphorylation, leading to a more efficient glucose uptake. And this facilitates glucose transport into muscle and fat cells, and chromium supplementation reduces postprandial hypoglycemia and improves HbA1c levels. So now you can see how this supplement worked for Mark's client. And this is obviously a really good supplement if your clients do have diabetes, type 2 diabetes, insulin resistance, or anybody that wants to prevent themselves from getting insulin resistance. Maybe they've got the genes for it, maybe it's in their family, or maybe they just want to maintain the overall blood sugar balance. A really good supplement for your clients to take. Okay, so this is actually the end of my slides, and there's just the references there if you want to have a look at those. Emma, back over to you.
Okay, perfect. Thank you so much for that, Ella and Mark. We've had some really good questions come through during that, so we're going to move to a quick Q&A round We've got about 10 minutes or so to do that. So I've got a couple of questions through. We've had a few questions from people asking if we can send through sort of like the relevant studies which have been spoken about. So obviously we mentioned before, but if we're able to do that at the end, that'd be great. We've had a question from someone who has said when we were talking about the ketogenic diet, she said that the ketogenic diet is great but challenging if the client is vegan. Please provide specific dietary suggestions for ketogenic approaches for vegans. I don't think who's best placed to answer that one.
I can answer that one. I've tried keto vegan actually myself, and it is a challenge. Yes, I'm not going to lie about that, but there are some fabulous resources out there. I have a cookbook actually called Keto Vegan, and it's really good. It tells you about like low carbohydrate beans that you can use as a source of protein. And, you know, like basically it's focused on low carbohydrate legumes and green leafy vegetables, low carbohydrate vegetables. But it's a really, really good starter. And I would say even if your clients aren't vegan or they're not vegetarian and they do eat meat, actually having the keto vegan recipe book is a really good one for them so that they don't have to eat so much meat all the time. I feel like with the ketogenic diet, there can be a tendency to have meat and cauliflower, and that's it. Whereas if you provide them a resource such as the Keto Vegan cookbook, that helps them to step away from having so much meat all the time and focus on a few more alternatives instead. So I hope that does answer your question. I think it's a case of, rather than me prescribing a certain diet now or like certain meals, it's a case of just going out there, finding those resources, and those books, Keto Vegan, are available online.
I also think the other intervention that'd be very helpful there will be the fasting, you know, so it's only, and sort of maybe mixing the fasting up a little bit, whereby we're not just doing sort of a 16/8, but we may actually sort of have certain days with extended fasts, because that would help the ketogenic process and actually sort of enable that mobilization of the fat from the adipocytes. So that will be my add to what Ella just said there.
I completely agree with you, Mark, on that actually. So yeah, so maybe if your clients are in a position to do so, they can do a 24, 48-hour fast as well. And also combining it with exercise, because if you do exercise, that does also help you get into the keto state as well. So kind of combining those things and getting into the keto state that way.
Perfect. Thank you both. Very helpful. The next question we have, I think this one is for you, Mark. So do you work with children or young people, and do you have any success stories of working with them to reverse type 2 diabetes?
I think the answer is very rarely, you know, sort of like obviously sort of as we saw from that graph, you know, the type 2 diabetes can take a while to actually develop. But if it is type 2 diabetes, you know, sort of like there's no reason why a similar intervention shouldn't work for a younger person as it does for someone of any age. So yeah, the answer is yes, I can. But rarely do I see that at this present time, which I must admit I'm sort of like is probably a good thing, you know, that I don't see that many sort of younger people with type 2 diabetes, because that would suggest that maybe you know, sort of there's maybe too much in the way of sort of like sugars, etc., within the diet. So yeah, I think if that answers the question. Yeah.
Perfect. Thank you for that. Next question is for you, Ella. So why does the fasting time frame change for women throughout their cycle?
Okay, so as the hormones kind of fluctuate throughout the menstruation cycle, women will find it much easier to fast in the first half of their cycle. So after menstruation, up to the point of ovulation, this is when progesterone is reasonably low. And progesterone is a carbohydrate-loving hormone. So up until this stage, women find it much easier to fast. You're going to be able to get extended fasts from them. You're going to be having much less cravings as well. After ovulation and towards menstruation, the body tries to keep progesterone a bit higher, which needs a few more carbohydrates. Okay, so I'm not talking about like eating cake or crisps or sweets or anything. I'm talking about like having less of a fast, so maybe having like a 12-hour eating window, and maybe incorporating some carbohydrates in there, like some sweet potato, not excessive, not like loads of, you know, carb-based meals, but having a few more naturally healthy, complex carbohydrates in there, and then starting again at the next cycle. So starting again, having that 8-hour eating window, having that low carbohydrate diet, and work on it cyclical. So a lot of women also, if you do constantly low keto or consistently low, fasting for 16 hours, they will have problems with their menstrual cycles. I hope that answers the question.
Thank you for that, Ella. The final question we have is for you, Mark, and this is, what is HOMAIR? I hope I pronounced that correctly. And how can calculating this be useful?
Sorry.
There you go.
So this is something I did cover a little bit when Ella went off air, but so it's actually the homeostatic model assessment for insulin resistance. So it's a calculation that's come about to sort of quantify when we can actually say someone is insulin resistant or not. So the actual calculation is a little bit complicated. It's actually the fasting insulin times fasting glucose and then divided by 22.5. So obviously a mathematician has come up with this assessment, but it can then a higher value of the HOMA-IR suggests a greater degree of insulin resistance. So if it's greater than 2, it's considered indicative of insulin resistance. But above sort of like 3.5, you know, it's then suggesting that there's a greater risk of some kind of cardiovascular problem. You know, so the higher the level, that the worse the actual insulin resistance is. So it's just a way of quantifying something whereby you're using both the insulin plus the glucose to actually assess what's going on with someone.
Perfect. Great. Thank you very much, both of you, for answering those questions. Okay, great. So that is about all we have time for this evening. So thank you, everyone, for your questions and for joining us this evening. A reminder that we will be sending out the recording of this webinar along with the slides and some other supporting materials, including a free handout which breaks down how best to support your clients with understanding insulin resistance. We'll also be sharing our practitioner paper, which breaks down sort of insulin resistance in more detail, as well as our glucobalance supplement, which Ella has taken you through this evening. And to those of you who have joined the webinar live this evening, we are giving you the exclusive opportunity to try our glucobalance supplement product for free, so totally free of charge, and details of how to claim this will be in the email that we follow up with tomorrow morning. You'll just need to complete a very short little feedback form for us with a couple of questions, just that we can take forward to future webinars, and then you'll be given a code that you can use on our website to claim the product for free. Just to note that we will only be giving this opportunity to those of you who have tuned in live this evening, so it won't be suitable for people who are watching on demand, I'm afraid. Also, just a note to say that our glucobalance supplement can also be purchased via the Natural Dispensary, as well as our website. I also just wanted to remind everyone that you are all invited to sign up to the DR.VEGAN practitioner scheme. By signing up, you will unlock a number of really great benefits, including commission on sales, clinical news, free products, and other practitioner-only perks to support your clients and to really help elevate your practice moving forwards. We'll be sending details tomorrow about how to sign up in the follow-up email, so look out for this. A final reminder that if there are any further questions that you want answered, please reach out to Ella. Her email address is on the screen now. It's ella@drvegan.com. She will be able to answer any further questions that you may have. And finally, just wanted to say a huge thank you both to Ella and Mark for being with us on our webinar this evening. It's been really insightful. I really hope everyone who has joined this evening has found the same. And it's been a really great second webinar as part of our new Practitioner Webinar series. And there's lots more very exciting things to come, so look out for this. But yeah, I hope everyone has a lovely rest of their evening, and we hope to see you all on our next practitioner webinar, which will be all about excipients and supplements. Details for this will be available on our website soon. We'll be sharing things on our socials probably from Monday onwards. So yeah, look out for these. But yeah, all that's left to say is thank you so much and have a lovely rest of your evening, everyone.
Thank you, Emma.
Thanks so much. Bye.
Thank you, Emma.
Oh, return this.